Good afternoon. Welcome to the webinar, How Small Amounts of Venous Air Can Increase Patient Morbidity. Thank you for your time and attention to hear new information on this important yet under-recognized patient safety issue. The webinar was made possible by Clearline MD, a company dedicated to patient safety and avoiding the adverse consequences of dangerous air infusion. Presenting today is Gerard Myers, a board-certified cardiovascular perfusionist and a well-published expert on microemboli and hemodilution and their clinical implications. With over 35 years of experience on the topics, he has presented both nationally and internationally and is an independent consultant for LivaNova Group in Italy and Instrumentation Laboratories in the US. His most recent editorial on venous air microemboli was recently published by the journal Perfusion in England. I will now pass the presentation on to Gerard Myers. Thank you.
Thank you, Abby, for the introduction. Good afternoon, everybody, or in some cases I may say good morning, depends on where you're located. Thank you for taking the time out of your week and especially out of your day. I know it can be really difficult to try to get some time to attend a webinar, so I truly thank you for attending these sessions. Hopefully over the next 45-50 minutes I may be able to give you some information that's going to help you have some new thoughts on venous air and microemboli, or just basically air getting into the vasculature, into the blood system. And maybe give you some new information that might change your mind. In fact, it may just reinforce some ideas that you presently have on the topic. As a perfusionist for the past 35 years, I basically live and breathe microemboli and air. Every day we go into work, we worry about air. We talk about it, we research it, we publish it, we present it. It's a topic that's of great concern to us because we know that microemboli getting into the arterial system can cause negative consequences to the patient and decrease patient outcomes. So we know it's a very morbid causing event if air gets into the arterial circulation. Now, there's many sources of intravenous air that we can talk about, but the only one that I want to focus on in this particular presentation is on air that gets in through the intravenous lines, air coming down the venous lines and getting into our intravenous lines and getting into the patient's venous circulation. So to do that, I'm going to take you through some of the aspects of arterial air so you can have a better understanding of microbubbles and microair and the damage that it does, and then you can relate that better to the venous side, and we'll talk about it as we're going along. Some of the things we're going to cover in this presentation are neurocognitive dysfunction, which is basically a change in the patient's cognitive abilities from the time they enter surgery to the time they leave surgery, or also in relationship to venous air. You may have heard it called neurocognitive dysfunction or postoperative delirium. It's another word that's often referred to. Endothelial glycocalyx, it's a very interesting topic, and there's a explosion of information at this particular point through the medical journals in regards to endothelial glycocalyx. We'll talk about that. Microbubbles and how they impact the circulation. Venous air emboli, obviously how it gets there, what it does when it gets there, what are the potential problems with it. Paradoxical air emboli, or basically arterial air emboli, because paradoxical air emboli is when the air gets from the venous circulation and crosses over into the arterial circulation, and it causes many problems coming from there. And finally, we'll be just touching on stroke. We'll be talking on stroke as it caused by microemboli or gaseous microemboli. I've been in this business I've been in healthcare for a long period of time. Over the past 35 years, I've been in perfusion. Prior to that, I was a respiratory therapist for about 9 years. So we know when we're talking about arterial air emboli, the three things that we basically talk about and we're focused on in preventing this microair from getting in the circulation is because of stroke. We know that it can cause stroke. It can be a serious event in regards to stroke. We know it can cause death. In certain amounts, it can cause death if it gets in the arterial circulation. And also it causes this neurocognitive decline or neurocognitive dysfunction. And that's just basically changes in the way people's cognitive abilities are affected during the surgery. But when we're talking about venous air emboli, the whole subject seems to change, and the only thing we tend to talk about in venous air emboli is death. So the focus in anybody listening to air into the venous circulation, they tend to get the general impression that if it's not under or over a certain amount of air, that it's okay to give them, because a little bit of air is never going to hurt anyone. If I had a penny for every time I heard that over the past 44 years, I'd be a rich man at this particular point. But nonetheless, this is what's focused on when we're talking venous air. So we really have not a lot of dialogue, a lot of language in regards to venous air emboli, anything outside of death. And that's what I hope to change with this presentation. When we're talking neurocognitive dysfunctions during cardiac surgery, they're associated with air emboli, arterial air emboli, and they're associated with some other things too that we'll talk about in the next slide or so. But the dysfunctions I'm talking about are things like psychosis and altered decision-making. Patients have memory loss, increased emotions, their attention span is shortened, they have language deficits like in speech or the syntax and grammar. They can appear as a depression, behavioral changes, agitation, visual perception, outbursts of anger, and paranoia. The interesting thing about neurocognitive dysfunctions, it's not the patient that generally recognizes. It's usually the loved ones or the family members, or even the workplace members that recognize this dysfunction in these people. And it's a real event. It does occur, and it can be devastating to some people. It could be long-term or short-term, but it can affect their lives in some very negative manners. So we know it's a real thing, and we know it's really one of the real causes of it is arterial air or microemboli. Interestingly enough, you can also get neurocognitive dysfunctions with venous air. This was shown by Yasser Alice and co-workers in the American Journal of Medicine, Emergency Medicine in 2014. And they were talking about retrograde cerebral air embolism. They're talking about air that gets into the venous circulation and migrates up through the internal and external jugular veins, lodges in the brain, and can cause this neurocognitive dysfunction. The things they point out in the neurocognitive dysfunction associated with venous air are anxiety, headache, confusion, agitation, syncope, slurred speech, blurred vision, and even seizures. In actuality, it's more or less similar to what the arterial air embolism will do. So we know it can occur in venous situations. When we talk about the causes for neurocognitive dysfunction in cardiac surgery, Patel and co-workers in the Cardiovascular, Psychiatry, and Neurology 2015, they pointed out some of the causes of neurocognitive decline in cardiac surgery patients, things like the patient's age, the comorbidities, the types of anesthesia, bad effects on blood pressure throughout the surgery, cerebral autoregulation gets affected, neuroprotective agency, hypothermia and rewarming, because we change the temperatures and warm the patients up, so that can increase microembolic counts during the cases. The type of surgery, even the length of surgery can affect a decline. But two of the other things I've got on the end, you see them highlighted, are microemboli and inflammation, because they basically go hand in hand. Microemboli actually cause the inflammation because they damage a very delicate lining within our at the interluminal part of our blood vessels called glycocalyx, which we'll talk about as we're going through here. So they really go hand in hand. If microemboli get in, it can damage the endothelial glycocalyx, and that causes inflammation, and that causes problems from there on. Patel and co-workers said that 50 to 70% of patients who have cardiac surgery can experience cognitive decline when tested within only 1 week of surgery. That amount decreases to only 30 to 50% of the patients after about 8 to 10 weeks. And then even after about 1 year, there's still about 10 to 20% of patients that can have some of these effects of neurocognitive decline. Now, make no mistake about it. I'm not saying that all forms, as I mentioned, of cognitive decline occur. There may be one or two or several forms of cognitive decline, but nonetheless, they can occur, and gaseous microemboli is a definite source of those microemboli, or one of the contributing sources of microemboli or neurocognitive decline. In pediatric patients, it's not so easy, because in pediatric patients, you can imagine they're not as easy to interview or to test their cognition before or after surgery, obviously. So it's difficult to diagnose in this group, but it's believed to be a leading cause of morbidity in this patient population. It really doesn't manifest itself until much later or until later in the child's developmental years, and it can show itself up as cognitive or intellectual impairments, attention deficits, visual impairments, and even speech and language delays. So once again, these microemboli can impact pediatric patients just as well as they can adult patients, but it just shows up differently. If you want to know about glycocalyx, or if you want to know about microbubbles, the only way to really understand microbubbles and how they impact the circulation is to understand two terms. Those two terms are glycocalyx and endothelial glycocalyx. Glycocalyx has been known to be around since the early 1900s. It's been around forever, but it's been known to be around with the early 1900s by physiologists. And it's a coating that exists on all cells, every mammalian cell that ever existed. And it's sometimes referred to as a sugar coating on cells because it's made up of these oligosaccharide and polysaccharide glucose chains that extend out of the cell walls. And it more or less protects the cell from fluid movement. It helps the cells for interacting with each other or attraction to each other. So it's an extremely important network around every cell for maintaining that cell's homeostasis. With endothelial glycocalyx, it's still glycocalyx, but it's the glycocalyx that's found on the endothelial cells within our blood vessels, within the interluminal part of our blood vessels. It plays an extremely important role in regulating fluid movement from the intravascular to the extravascular spaces within our vasculature. It protects our endothelial cells. It regulates colloid movement. It controls colloid movement. So it's extremely important. The interesting thing about endothelial glycocalyx, it was discovered in 1966 by a physiologist by the name of Luft using an electron microscope, and he was examining coronary arteries in rats. And since that time, there's been an increasing interest into it. But since the year 2000, there's really been an explosion of interest and publications in regards to endothelial glycocalyx and glycocalyx. In fact, if you look in the PubMed and put in endothelial glycocalyx, you'll come up with over 900 articles, and 87% of those 900 articles have only appeared in the literature since the year 2000. So it's helping to explain a great deal of things that goes on through many disease states, through sepsis, through diabetic patients, etc., damage with microemboli. So I'd encourage you to look more into it if you can. So endothelial glycocalyx really, within the intravasculature, the interluminal part of our blood vessels, it's a negatively charged gel-like layer that grows out of the endothelial cells and is comprised of glycoproteins, proteoglycans, and glycosaminoglycans. It can range in thickness between 0.1 microns in the capillaries to as much as 4.5 microns in the carotid arteries or larger blood vessels. Now, from our education and our experience and our training, we tend to think that the red cells and the platelets and the white cells, all of our blood components are in constant contact with the endothelial cells. But in fact, that's not true. Because of the endothelial glycocalyx, it prevents all of the formed elements of the blood from ever contacting the endothelial cells. In fact, that's one of the reasons why they called endothelial glycocalyx the exclusion zone, because it prevents the formed elements from ever touching the endothelial cells. When the glycocalyx is broken down and damaged, and it does contact the endothelial cells, bad things start to happen. That's when you get inflammation, edema, colloids leak out of the vasculature just as easily as others, thrombus formation, small microbubbles can adhere to the endothelial cells and attract platelets and white cells. So it's a really bad thing when that glycocalyx layer gets broken down. If you take a look at these two particular slides here, you look in the upper portion one, that's actually a bacterial cell. And if you look around at the hair-like structures all around the outside of it, that's these oligosaccharide, polysaccharide glucose chains that are extending out of the cell wall. And again, it's on every cell known to man. The lower portion is a picture that was taken from Vink and co-workers. They're out of go to the Netherlands. They've done quite an extensive work in regards to endothelial glycocalyx. And you can take a look, if you look at this as a slice of the coronary artery, if you look at the outside portion of this cell, I call it the basement membrane, that's the endothelial cells. And growing out of those endothelial cells is actually these oligosaccharide, polysaccharide, glucose chains that are extending into the interluminal part of the blood vessel. And around the entire the vessel wall itself, you see that gel-like lining that I was talking about. That gel-like lining is an extremely important structure. It contains many important molecules like antithrombin 3, chondroitin sulfate, heparin sulfate, dermatan sulfate, albumin. And because of that, it plays a very important role in regulating fluid movement in and out of the blood vessel walls. You can also see, because of that gel-like layer, why the red cells, white cells, and platelets never contact the endothelial cells, because you can see this exclusion zone keeps them away from the endothelial cells. And so you can imagine that when it's damaged by microemboli, such as gaseous emboli, and there's many other reasons why it can be broken down in sepsis and volume loading and other things. But once it's damaged, that's when bad things start to happen. So there's a researcher out of Wake Forest University in I think North Carolina. His name is Dr. Stump, Dr. David Stump. He's been studying emboli, solid emboli, lipid emboli, gaseous emboli for the past 2 to 3 decades. And he made a statement back in 2005. He said that gaseous microemboli are well-documented endothelial irritants and can cause significant brain dysfunction. The passage of a single embolus through cerebral capillaries can initiate cerebral swelling and intracranial hypertension. Now, if I'd have told you a single embolus can cause cerebral swelling, you might question it, but that was before I told you about glycocalyx. You can imagine that a single embolus, if it damages that glycocalyx, that's where you get cerebral swelling, because you get fluid movement out of the intravascular space and you get inflammation and edema. And obviously, the more edema you have, the more chances you have of ischemia occurring downstream, because you're reducing blood flow going through that particular small vessel, that small capillary. Barak and co-workers in 2008 said that during the course of a microbubble through the microcirculation, the bubble damages the native endothelial cell surface area called the glycocalyx, initiating inflammation, edema, and activation of the complement coagulation system. I just want to show you this picture here. This is from Myberg and co-workers, New England Journal of Medicine, 2013. And they were talking about resuscitation of fluids, because one of the other things that can damage glycocalyx is if you give 1 or 2 liters of fluid rapidly, sort of a volume loading process. What can happen is when you stretch the walls, the atrial walls of the heart, it releases a natural hormone from the cardiac myocytes called atrial natriuretic peptide, or ANP. And this ANP is a good vasodilator. It starts diuresis. But the problem with it is it damages glycocalyx. So even though you're trying to improve a situation by giving fluid quickly, if you damage glycocalyx, you're actually complicating the situation because fluid movement changes. And so what he depicted up in the top here is this is a healthy glycocalyx, and you can see the plasma water, plasma circulating, the red cells circulating. And there's an equal exchange between plasma proteins, in this case albumin, between glycocalyx and the plasma water. But when you have a damaged endothelial glycocalyx, you can see these plasma proteins will leak out into the endothelial cells and interstitium just as easily as crystalloids will. And that's where you get inflammation, and that's where you get edema. And I always like to say that a picture is worth 1,000 words, and I didn't invent it, of course, but I heard it somewhere, but it's true. To me it is, anyway. Bubbles in water. This is what we have a vision. When we think about bubbles going into a patient, we think about these round little spherical things that you see in your beer, your champagne, and boiling water with the smooth sides. But in fact, this is what bubbles look like when they're in blood. What you see here is this is bubbles that enter the blood. Anything that enters the blood, that includes air, microbubbles or volumes of air. When it enters the blood, it's immediately treated as a foreign object. So it's coated with plasma and proteins, or it's coated with proteins and albumin. White cells will adhere to it. Platelets will adhere to it. So it becomes a pretty formidable object in the sense that the walls are thicker. It becomes a little harder to absorb. The interesting thing about microbubbles is that once they're into your blood, they have this unique capacity to do what's called coalescence, where they actually, if they touch each other, they can form larger bubbles. So you may have a bunch of small bubbles, but if they touch each other, they can actually form larger bubbles and grow into bigger ones. And when these bubbles pass through the microcirculation, they can be just as damaging as solid emboli in regards to the glycocalyx. Now, it depends on who you read, but whatever physiology journal you read, you'll note that systemic capillaries are 4 to 9 microns in diameter. Pulmonary capillaries are 5 to 6 microns in diameter. But if you've got an air bubble coming down your IV line that's only 1 millimeter in diameter, that's actually 1,000 microns in diameter. So that's a massive bubble in regards to the microcirculation. Now that bubble, we'll talk about a little later, that volume of air gets broken up into many smaller microbubbles when it hits the heart. But nonetheless, even though it's only 1 millimeter, that's a very small bubble. It can be a considerable size in comparison to the microcirculation. What I'm showing here is this is a picture. This is not an air embolus. This is a lipid embolus that was trying to pass through the microcirculation. As you can see, it's only a 20 micron air embolus, as you can see down here with the scale. But as it was trying to pass through the capillary network, you can imagine the damage that it did to the glycocalyx lining as it's passing through there. If it had managed to get through from that point on, you can imagine the breakdown and the fluid, the inflammation, the edema that can occur from that point on, simply because of destroying the glycocalyx lining. Unfortunately, this is the consequences of massive air going to a patient during cardiopulmonary bypass. This is every perfusionist's worst nightmare if this happens. The air, obviously, a lot of it gets to the brain. This is obviously a post-mortem slide. And what you can see is this is the air going through the microcirculation. You can see it's more like a sausage shape. Air bubbles don't pass through the microcirculation as a bubble, as a round object or egg-shaped object. They pass through in a sort of a sausage shape, as you can see in this particular slice here. And you can see the capillary networks where it didn't get through. And you can also see other areas if you look at these red circles around where the air also lodged in the capillary networks. So I want to give you just a sort of a visual experience in regards to volume of air that we talk about in venous air to microbubble amounts, microbubbles that we talk about in arterial air. This was just a study that was done by Guan and co-workers in the Journal of Extracorporeal Technology in 2010. And it was just an in vitro study done in the lab. They were using an extracorporeal circuit, and they were testing different ways of putting air in and seeing if it came through the membrane. So they were using a device, a Doppler technology device called the EDAC quantifier. And it's a probe that you put on the line, and you measure air, you measure blood flow going by it. If it detects air, it gives you a signal. But what it reads in, it'll give you two readouts. One will be in volume of air that's gone by, and the other one will be in the microbubble counts, or GME, gaseous microemboli counts. And they did this for over a 3-minute period. And what they found with the technique, whatever they were testing with, they found that over that 3-minute period at that one sensor, there was almost 40,000 gaseous microemboli that were detected going past that particular sensor. That equated to, it was broken down into sizes. It equated to 18,500 microemboli that were 1 to 20 microns in range, those size that they will probably pass through the microcirculation unimpeded. Over 9,400 microemboli were in the 20 to 40 micron range, and almost 12,000 of those microemboli were in the 40 micron plus range. In other words, we don't know how big they were. They were just greater than 40 microns. So that's a considerable amount of microemboli in a 3-minute period. But when you took a look at the volume of air that this microbubble, these 39,000 microbubbles equated to, that volume of air was only 0.29 mils. That's less than half a cc of air. generated over 39,000 microemboli. So just because we have a small volume of air going into the venous circulation doesn't necessarily mean that small volume of air is going to stay in that form, because it's going to be generated into many thousands of microemboli once it hits the heart. Venous air emboli, you can trace back the morbidity and mortality related to venous air emboli going back to the early 19th century, in 1839, 1885. And of course, at that time, they were doing studies in animals, and they were looking at how much air killed an animal. And that's where you get the volume of air, what's safe and what's not safe, and we're talking about volume of air. It's really, when we're talking about air in entering the venous circulation of patients on a daily basis, it's almost impossible to determine how much venous air enters the bloodstream every day through intravenous lines. And I'm not talking just in your local hospitals. I'm talking about in North America, in the world, in all countries. It's a situation that's encountered every day. Venous air gets into intravenous lines every day, and it all depends on how it's handled, whether that air gets to the patient. But generally, if you talk to clinicians, they really have basically two general opinions about venous air in an IV line. One is that it's a problem during routine clinical care. It's a problem that has to be addressed. It has to be manually removed. If you don't have an air removal device to take it out, it has to be manually removed. Many times, unfortunately, people are justifying that it's nothing to worry about. I know many patients will ask, and many patients will be told, "Don't worry about it. It's not a problem." And this has got to do with education, got to do with passing on a way of looking at venous air that we don't have at the present. And the second opinion is that if a little bit of air is not going to kill you, well, why are we worried about it? Well, the reason we're worried about it is because I'm trying to give you that information now so that you can understand why we should worry about it. Because it can impact your patient's outcomes, and it can impact your patient's your physiology at that particular time. So when we're actually looking at venous air, we're really looking at a culture, a long-term culture, I mean a decades-long culture, many decades-long culture of misinformation around venous air. It's truly a lack of education. It's something that's passed on from generation to generation, instructor to student, peer to peer. It's in every avenue of healthcare when we're talking about venous air. And nobody ever intends any harm or assuming any harm or not even imagine any harm. It's just that the knowledge that we presently have around venous air is that you can give venous air up to a certain amount and it's not going to harm the patient. That's the unfortunate attitude that we have right now. In fact, the attitude that we seem to have is that any amount of air under 50 cc's, if it goes to a patient, it's not going to harm the patient. Well, hopefully I'm trying to change your opinion on that by giving you reasons why you should be concerned about it and why it does damage patients. But the topic is debated a lot, but mostly it's just debated and then it's ignored. Not because it's ignored because that's a bad thing. It's just ignored because the general pushback is that there's no evidence to show that micro-air will cause problems to the patient. And I'm telling you, quite to the contrary, there is evidence to show that micro-air is damaging to the patient. So some of the sources of air in an intravenous line can be gravity-fed intravenous lines, especially when you're changing bags or piggybacking drugs off to the side of IV lines where you see an air bolus coming down. It can come through IV lines that's fed by a pump or a pressure bag or syringe-fed IV lines. Blood warmers are an offender where it's warming up the solution. You can actually take air out of the IV fluids, and that's where it produces microbubbles. So they become a problem. Renal dialysis patients have a real problem with it because during renal dialysis, you're actually using the mechanical pump to draw air from the venous circulation into the venous circulation or from the arterial side back into the venous side, whichever they're using. Just let me check up here to see something here for a second. Okay, sorry for that delay. I hope that's better. I can see myself there. Hopefully you can see me. I have to sit up now that I can see myself. Sorry about that. Renal dialysis patients it's a real problem with them because air gets into their lines, and it's a true problem with them in getting rid of that air during the procedures. It'll shut off pumps and set off alarms. Interesting thing is that rapid pressurization infusion through small bore cannulas like 12, 14 gauge, 21 gauge cannulas, whatever you've got indwelling in the patient. If you take a syringe, even though that syringe is full of fluid and it's there's no air into it, and you inject it rapidly through that cannula, you can actually draw air out of solution at the cannula tip as it's in the patient's vein. The reason for that is it's called cavitation. Because of the changes in pressures, the Bernoulli effect, the turbulence at the end of that cannula, you'll actually draw air out of solution, and that air, most of it will go rapidly back into the blood, but some of it will not. So how do we know that? We know that from cardiopulmonary bypass because of the cannulas we use are anywhere between 7 millimeters and 9 millimeter cannulas. And if you go on bypass rapidly through these narrow cannulas and try to get your flows up quickly, you can measure with Doppler technology a massive amount of air coming out of the end of these cannulas. So we tend to go on more slowly, and we tend to make sure that the fluids that we're going on with are the same temperature of the patient. So that's another thing to be concerned with. Now I just want to show you this particular picture here. This picture here is obviously the venous circulation through the patient's arm. And you can imagine anywhere where you're putting in an intravenous line, whether or not it's in the hand, in the cubital space, wherever. If the fluids are coming in and any air gets in with that fluid, it'll eventually come up and it'll reach the subclavian veins, the right and left subclavian veins, depends on which arm it's going through. And as it leaves the subclavian vein, it comes down the brachiocephalic vein, down through the superior vena cava, and then into the patient's heart. But what I want you to take a note of is right up here at the top, just as the subclavian vein starts to come down into the superior vena cava, you've got the internal and the external jugular veins on both sides. So if that patient happens to be in a sitting position and there's air coming in, it really depends on the patient's heart rate, the blood pressure, if there's any arrhythmias, whether or not some of that air is going to go up into the internal jugular veins and as such be called retrograde cerebral air embolism. So that's something to be concerned with, especially if the patient's in the sitting position. Speaking of in the sitting position, venous air emboli have the potential to move up into the superior vena cava, into the jugular veins, into the cerebral circulation, and that's called retrograde cerebral air embolism. That was shown by Schlimp and co-workers in a couple of papers in 2005 and 2006. In the supine position, when patients are laying down, if air gets into the venous circulation, it can, sorry about that. It can enter the cardiac chambers, but it can sit in the ventricles and stay there for periods longer than 45 minutes because it just sits in the cardiac chambers before it's either eventually absorbed or it gets dislodged when the patient sits up, or it gets just dislodged from the ventricle during contraction. What you got here is this is a picture of a 35-year-old female that was going in for a CT scan for some renal stones or renal calculi. And what you can actually see, if you take a look at this arrow up here, you can see this is air sitting in the right ventricle of this patient that when they were looking for renal calculi, they noticed air sitting in the right ventricle. What was interesting about this is this patient had an intravenous line put in an hour before coming for the procedure. So there's no doubt that the air came in through the intravenous line and is now sitting in this patient's heart in the right ventricle. As to where it's going to go, it could get dislodged when they sit up, or it could get dislodged during contraction, or partially maybe get absorbed. So what happens to venous air or when it comes through an IV line? If you see air coming down an IV line, depending on what portion of it's coming down, how much air is coming down, you tend to think that air is going to come down, it's going to enter the patient's circulation, it's going to go to the heart, and then it's going to go to the lungs. The lungs are going to get rid of it, and everything's going to be okay. But in actual fact, what happens to that volume of air that comes down, if it gets past the jugular veins and does get into the patient's heart, what happens to it, it actually gets beaten into many thousands of microbubbles. It more or less acts as a beating chamber. As the heart, the atrial walls are contracting, the ventricular walls are contracting, and while that air is sitting in blood, it basically gets churned into many thousands of microbubbles that one big bolus does. And because of that, it almost turns into, depending on the amount of air, it can almost turn into a foam, where it'll activate platelets, it'll cause fibrin formation, and where that goes really depends on a lot of things, but it can pass off into the pulmonary circulation, where hopefully most of it will get handled. Most of it will get handled by the lungs, but maybe not. Or it can pass up in a retrograde fashion to the superior vena cava, the jugular veins. Or it can pass over into the left side of the heart through openings in the atrial walls or in the ventricular walls. So it basically can go many places. Once air is crossed over from the right side of the heart to the left side of the heart, it's called paradoxical air emboli, or PAE. PAE are really important risk factors for strokes, transischemic attacks, and neurocognitive dysfunctions. Some of the sources for PAE, there's really four sources. There's the patent formative valleys, atrial septal defects, ventricular septal defects, and what's called interpulmonary arterial venous anastomosis, or IPAV shunts, IPAVA shunts. These exist in the lungs, and we'll talk about them in the next coming slides. As we know, patent formative valleys are they're obviously in fetal circulation. They're essential to the fetal circulation, but at birth they generally close at birth, and within a couple of days, in most cases, they're generally closed. But some patients, they don't close, and they carry forward into the adult life. They can still be present, but they just have not become symptomatic at that point. It's believed that to be present, and in fact, in about 30 to 35% of adults. So that means every 3 out of every 10 adults that you would see in your clinics or in your hospital could potentially have a patent formative valley. On autopsy, Ladowski and co-workers looked at an autopsy, and they actually found patent formative valleys to be present in 40 to 45% of hearts during autopsy. So this essentially means that every 3, you can have 3 to 4 adults out of every 10 adults that come into your clinic or hospital that have patent formative valleys. In regards to atrial septal defects make up about 30 to 40% of adult congenital heart defects. So they can be present in adults until they're detected and treated. In regards to VSDs, there's about 300. It's estimated that there's about 300 VSDs per 1 million of the adult population in the United States. When we're talking atrial septal defects, they come in 3 forms. You have the sinus venosus defect, which are the ones up in the upper portion of the atrial walls. They only make up about 10% of the ASDs. You get the secundum ASDs that exist in about the middle portion of the ventricular, the atrial walls, and they make up about 70% of the ASDs that are present. And then you get the primum defects that sit in the lower portion of the atrial walls, and these ones exist about 20% of the atrial septal defects, but they can impact the mitral valve, can be slightly more serious, or more serious, I should say, not slightly. In regards to the VSD, they come in 2 forms, either the membranous types that fit in, that are in the upper portion of the ventricular walls, or in the muscular portion of the walls down below. They can exist down there as well. So these interpulmonary venous arterial shunts, or IPAV shunts, are exactly, they're about 25 microns in diameter, as opposed to a capillary, which is about 4 to 9 microns in diameter. And they exist in the lungs. And what they do is they're actually shunts that bypass the alveoli in the lungs. They don't contact an alveoli to allow gas exchange or allow air to move out through the alveoli. They actually bypass the alveoli, and they go directly to the left side of the heart. So if there's any air ejected from the right ventricle going through the pulmonary artery, going to the pulmonary circulation, if it gets into the IPAVA shunts, it'll bypass it and go directly over into the left atrium, which then goes to the left ventricle. And the first vessels that, when the left ventricle contracts, is the three head vessels as it comes out through the aortic arch. So these IPAV shunts, or IPAVA shunts, can be found in about 28% of people at rest. That's about 3 out of every 10 people. Or during exercise, they actually increase, and they can be in over 95% of adults during exercise. So we know, or we tend to think, that air is removed by the lungs, because that's the hope we have, that's the impression that we have when we're talking about air being removed by the lungs. And the way that occurs is more or less the same way it occurs in the devices that we use during extracorporeal circulation, the membrane oxygenators that we use. It's basically based on a pressure gradient. It's not a result of the PO2, the FiO2, the CO2. It's based on a pressure gradient as this air emboli is being removed. Because what happens is the lungs themselves have a huge surface area, and the amount of alveoli, these air sacs that are located in the lungs, are estimated to be basically over 480 million, give or take a few million. But in regards to the alveoli sacs themselves, the pressure in those alveolar sacs is generally constant between -1 and +1 millimeters of mercury. But the pressure that's coming in from the right ventricle, pumping the lung, pumping through the pulmonary capillaries, the pressure in those capillaries is about 8 to 12 millimeters of mercury. So what happens is when the capillary blood passes by the alveoli, it's just a matter of physics. Air flows from an area of high pressure to an area of low pressure, and so those microbubbles actually pass out into the alveoli because of the pressure gradients between these two. Unfortunately, when you've got the IPAVA shunts, as you can see here, these shunts bypass the alveoli and go directly to the heart, or to the left side of the heart. What happens in this situation when the patient's intubated and on a ventilator and got PEEP on, where you're increasing the pressure within the alveoli up to 5 or 10 millimeters of mercury, I really don't know for sure what happens if any air gets into the venous circulation. In that case, it would be my guess that it doesn't get removed as efficiently as it would in a normal functioning lung. It'd be my guess. There's no evidence, but it'd be my guess. So what happens when air and the left side gets into the left side of the heart? Well, one of the things that it can do is it can lead to ischemic strokes. It can cause ischemic strokes. 87%, these authors, Roseman and Waldler, found that 87% of all strokes that were reported in the United States were found to be ischemic strokes. And 30% of these ischemic strokes were found to be embolic in nature. Ischemic strokes that occur with an unknown etiology, in other words, they don't know why they occur, they're called cryptogenic strokes. The IPAVA shunts are also suspected to be potential sources for cryptogenic strokes. And patent formative valleys are actually found in up to 60% of patients that have cryptogenic strokes. So to summarize this whole presentation, it really comes down to this last slide to give you a summary of it. When we're talking about the morbidity that's associated with intravenous air, hopefully I've given you enough information to show you that, first of all, it can cause neurocognitive dysfunctions, whether it gets into the venous side or whether it gets in the, if it's into the venous side and gets retrograde up into the circulation, as we know, it can cause neurocognitive dysfunctions. That was shown by one of the previous slides I was showing you. If it gets to the arterial side, obviously it can do the same thing. Venous air can also damage or degrade the endothelial glycocalyx, not only on the venous side, the pulmonary circulation through the pulmonary capillaries, but if it gets to the arterial side, it can do the same thing there. And that causes inflammation, edema, activation of the complement coagulation cascade, and basically bad things can happen to the circulation. We know that venous air can activate platelets. If it gets into the ventricular chambers and causes a foam-like structure, it can activate the platelets. It can also cause fibrin formation in these areas. And there are also potential sources of strokes, not only on the venous side, but also on the arterial side. It can be a potential source for strokes and transischemic attacks. So finally, we have to say, well, how do we prevent IV air from getting into the intravenous line? Well, first and foremost, and by far, what we have to do is we have to educate healthcare professionals. I'm talking all healthcare professionals, not just in the nursing and the medical professions, but in any profession that deals with intravenous lines. We have to educate them on the hazards and the morbidity associated with venous air. This is a serious lacking situation that we have in healthcare today, because we're just creating generation after generation of people that believing that it's okay to give 50 cc's of air into a patient's venous circulation, and that patient's going to be the same and not have any potential problems, when essentially you could cause major problems to that particular patient. So education is by far the first thing that needs to be done. The second thing is that if that doesn't take place, you either have to prevent or manually remove the air in the intravenous line. We don't need to placate patients by telling them that don't worry about the air, it's nothing to worry about, because patients are going to see it, they're going to pinch the IV lines and ask you, what is that a problem? And they're going to rely on the practitioner to tell them whether it's good or whether it's bad. It should be removed in all circumstances, and in the first place, it shouldn't even be there. The third thing, we can use intravenous air removal devices like the Clearline MD device that's being used. This, as far as I know, this is the only device that they could tell you this, but it's my knowledge of it. It's the only federally FDA approved device for removing air in intravenous lines, and if you want to contact them, they could probably tell you more than I can. And also the other situation is you can use IV infusion air filters. From what I understand, these are very sensitive. They can be more problems than they can be benefit, depending on where they are, but they're used very frequently in pediatric patients as far as I know. So with that, I'll call an end to this session.
Thank you for attending the webinar on how small amounts of venous air can increase patient morbidity. We hope you found this informative. For more information on Clearline MD and its patented FDA-cleared technology that automatically and continuously removes air from IV lines, please contact us at info@clearlinemd.com and visit our website at clearlinemd.com. Thank you for your time.